Well, hello, thank you for coming. I wasn't expecting quite so many people, so I'm a bit daunted. But so I'm Nikki Thomas. I manage the recovery and rehab community mental health team at the Oberlins. And I've put this presentation together to just have a look at some of the health inequalities that exist within the service user group that we care for, people suffering with severe and enduring mental health conditions, and also to highlight some of the things we're doing in my team to try and address those inequalities. I would say that we're nowhere near, addressing the inequalities as they are at the moment, but it's a work in progress, but I do feel very committed to improving the discrimination and stigma that some of our service users feel. So that's me. My team, very quickly, is made up of psychiatrists, a clinical psychologist, occupational therapist, and lots of registered nurses and support workers. Between us we manage a caseload. I think we have about 76 or 78 people on our caseload, and they generally comprise of patients who are perhaps the most chronic and have the most sort of significant functional deficits because of their mental illness, so they're quite debilitated in many ways. I put this quote up here. It's a nice definition of health, I think, and it gets us started in terms of thinking about what health means for people. And it's not the absence of disease or infirmity, but it is about complete physical, mental and social well-being. And our team strive to try and support people to achieve a balance in their life and to achieve a quality of life, albeit living with severe mental illness. So what we know about mental illness for this particular patient group in terms of their physical health, these are just some facts, and I'm sure that you'll be surprised by these, as was I. So poor mental health is recognised as a major risk factor in the development of conditions such as cardiovascular disease, diabetes, chronic lung disease and cardiometabolic syndrome. You can see the mortality rates are 2 to 3 times higher than in the general population amongst this group. There are lots of statistics, so it's a case of just picking some out, but people die between 13 and 30 years earlier if they have a severe mental illness. People with schizophrenia are twice as likely to develop bowel cancer as well as other cancers, twice as likely to die from coronary heart disease. Women are 42% more likely to be diagnosed with breast cancer, 3 times as likely to be alcohol dependent. And I think some of these statistics are absolutely shocking. And as mental health professionals, I think we have a duty to make sure that we are addressing these health inequalities, because there are things that we can do. The BMA have suggested that prevention and early intervention are key, and in order to achieve that, we need to be thinking about workforce planning, have a greater focus on research in mental health, in mental and physical multimorbidity. There's masses and masses of work being done in the UK, and I think in Guernsey we're a little behind, and I'm hoping that through some of the work we're doing in our team we can start to roll out some of the strategies to wider mental health teams. So contributing factors affecting physical health. Psychiatric illness in itself will contribute to physical health difficulties. Negative symptoms such as lack of motivation, lethargy, apathy, poor concentration, poor drive, all of those things will affect people's ability to address their physical health needs. I've put disorganised thinking, lack of self-esteem, poor cognition are key factors for why many of our patients don't access help when they need it. Psychotropic medications, you may or may not know, cause significant weight gain. Some of the new atypical antipsychotics can increase people's weight, and as a result causing type 2 diabetes, cardiovascular disease. And again, you know, as prescribers and as clinicians working with this population, we absolutely have a duty to help people manage their physical health overall. And then of course we've got lifestyle factors. I've just put a few things up here. Drug and alcohol misuse, which is prevalent in this group. Smoking, poor diet and obesity. Poverty, it's a huge issue in terms of people being able to access the sorts of things that will help them with their lifestyle. This group have lower educational outcomes, poor employment opportunities, reduced social integration, weaker social relationships, and as a result can't assertively seek the support they need for their physical health problems. There are psychosocial and economic factors too. So it's well recognised that this patient group are much less likely to access and utilise primary care or public health initiatives. Lots of reasons for that, and I'm sure you would come up with these reasons yourself. They're not new, but certainly stigma plays a huge part, both from the perspective of the patient feeling that they will be judged or not understood, and stigma from services. Many of our patients will access primary care and have their condition misdiagnosed because it's been misinterpreted as somatising, or the patient hasn't been able to communicate effectively. The disincentive financially of attending the GP, that's a major factor. Many of our people are on benefits, but actually what we find is that they can't afford the bus fare or the taxi fare to get to the GP, and so they just won't prioritise that. Disparities in healthcare provision is well documented, and things like access to routine screening, regular health checks is underutilised, poor detection of health conditions, and what's really clear is the lack of clarity about whose responsibility it is to manage a patient's physical health. And it's not just the GP's responsibility. Specialist mental health services have a duty to manage physical health conditions as we're prescribing medication, which has such a profound impact. And staff training and development. I think many mental health nurses would hold their hands up and say that they don't feel equipped. They don't feel that they're skilled enough to be thinking about a patient's physical health and undertaking those checks. So these are some of the conditions that that we see in this particular population. Metabolic syndrome, which, as I'm sure you know, is a cluster of conditions including raised blood pressure, raised blood sugar, excess body fat around the waist, and abnormal cholesterol, obesity, cardiovascular disease. These are all conditions that are patients at more at risk of getting. So what can we do? It's not all doom and gloom. There's lots that is being done in the UK. There's some really wonderful initiatives, and I've had a look at some of the strategies, and they're really not that difficult to implement. It's just a little bit of a change of approach and a change of attitude in specialist services and in the way that my team, for example, can help people manage. So bear with me. So we can promote access to health improvement initiatives in the community, and it's really important that we link our people in with things that are already existing, things like Quitline, Weight Watchers even. There's lots going on, and we just need to help our particular service users access that, and that can be something as straightforward as giving them a lift or going alongside them to give them confidence to attend. Embed provision of health promotion within specialist mental health services. So that's about just skilling ourselves up really to help people understand the importance of quitting smoking, increasing exercise, having healthy nutrition. Partnership working with primary care is absolutely key, and I think there's a long way to go for us to communicate better with GPs and other primary care workers. Following national guidance when initiating psychotropic medication, NICE guidance I'm talking about there, making sure that we're clear about what we need to do in terms of monitoring when people start on psychotropic medication. Looking at some validated tools. So one of the things that we've started using is this document called My Physical Health. It's really straightforward. It's a lovely assessment document where you can get a really good sense of the person, what their health condition is, gives you a good baseline, and the plan is to complete one of these as a minimum annually, and then as issues are thrown up, obviously you can revisit it regularly. And there's a tool here called the Leicester Cardiometabolic Screening Tool. Again, it's a really lovely resource which gives you clear pathways when you're looking at a patient's physical health. So those are the kind of assessment things that we can do. Getting all of these tests and assessments done annually. That's all fairly self-explanatory. But there's lots more we can do too. So we can support our service users to seek help and access to screening and primary care through collaboration, trust, education and support. And I think it's really important because many service users that we care for don't have the confidence to seek the support they need, and they certainly don't have the practical means of accessing that support. So when I first started in the team, a lot of people used to say, it feels like we're a taxi service. Well, do you know what? Sometimes we have to be a taxi service, and that's all right, because that actually gets people to the dentist, it gets people to the sexual health clinic. But one of the other things that we've just started doing is we've bought into a membership at Beausejour. So my team pay £100 a month, and that provides access to a smaller gym downstairs, which they've just developed, for an hour a week for any of our service users to go to, so they can drop in, spend half an hour, never go again, or they can go regularly, and it can be for any of my 78 service users, because the LifeFit memberships are specific to individuals, so we found that a bit prohibitive. And that has proven to be really successful. Lots and lots of patients have dipped their toe in, maybe come back once or twice, but are beginning to think about addressing some of their health issues through the gym. The people that run it are brilliant, and I'm hoping to extend that out. So I've asked for next year to have more sessions through the week. We also have, we've just been given £2,500 from the Bright Ideas Initiative, and we're hoping to, part of that, we're going to be buying tablets or iPads for patients, and part of that will be getting some apps downloaded in relation to physical health. It could even be the Weight Watchers app, whatever, we're still thinking about that, but I'm hopeful that next year we'll be able to do a lot more. So that's it. Thanks for listening, and any questions?
Hello, I'm Annabelle Nicholas. I'm the matron for maternity services. And we were looking at how HSE ensures quality and safety for women from Alderney who access our maternity service. So you might actually be able to identify some of the service users and staff that I refer to during this talk, so it's just a reminder that this is all confidential. And firstly, if we just look at the national drivers for quality and safety, we've got the Francis report, which looked into failings in mid-staffs. and came up with 290 recommendations. The Kirkup report looked at failings in maternity care at Furness, where it was thought that incidents hadn't been adequately investigated and the deaths of 11 babies and 1 mum could have been prevented. And also in 2016, the National Maternity Review is a paper that looks at continuous improvement in maternity services going forward. So what situation did we find ourselves in? So this was when Elaine Torrance and I first came into post, and in January 2017 we found that babies were still being born in Alderney despite advice to the contrary, and there was no midwifery or obstetric support in Alderney. So we know that 23 babies have been born in Alderney since the year 2000, and that's despite the fact that I believe for about 30 years the advice has been to give birth in Guernsey, and that was following, I can't find any documentary evidence for this, but that was following a maternal death, I think, or a death of the baby in Alderney about 30 years ago, which was thought to have been preventable had there been access to obstetric or midwifery support. So then in January 2017, in inclement weather, a lady went into labour in Alderney, laboured quite quickly. She was attended by the 2 ex-midwives and 2 GPs in Alderney, but unfortunately she developed a potentially life-threatening complication. She had to be transferred on the lifeboat because of the fog. Unfortunately, it was thought that the baby couldn't go with her because if the mum's condition deteriorated during that transfer, it was felt that they couldn't look after the baby as well. Fortunately, she was fine, and she was reunited with her baby the next day. In 2016, one of our midwives was on a New Year's break when a lady went into labour, and she received a phone call to go and attend that birth. And then in March 2017, one of our obstetricians was in Alderney doing her quarterly gynaecology clinic when again a lady went into labour and she attended. But there's no theatre, there's generally no obstetricians and generally no midwives, and only basic emergency equipment in Alderney. So that obstetrician was in a dreadful predicament really, because she had the skills to be able to save that mum and baby's life should she need to, but she wouldn't have had the environment or equipment to do so. So, as I said, pregnant women from Alderney have been advised to give birth in Guernsey for at least 30 years, but there was a bit of a lack of clarity and consistency of how this information was conveyed to the population of Alderney, and HSC and the midwives and the maternity department. It was all very ad hoc. So we started to look at this. Obviously it was worrying having the 2 births in 2017. And I like to look at things in terms of the CQC domains. Personally, I just find them really helpful. Safe, effective, caring, responsive and well led. And one of the questions that the CQC often ask is what keeps you up at night? And certainly after those 2 births in 2017, it was Alderney, and still today might be something that keeps me awake at night. So, this sleepless nights and leadership insomnia. The issue of birth in Alderney became an immediate priority, and we put it on the risk register, didn't we, Martin? Straight away. And so where did we begin? And what did we need to ask, really? Were we safe? Well, there are no midwives in Alderney, no equipment, no obstetrician. So we spoke to the head of midwifery in Cornwall, because they look after the Scilly Isles. They do have a midwife in the Scilly Isles, but it's a fairly niche position. She's paid for 30 hours a week, but she's on call, I think, for at least 3 weeks, 3.5 weeks. She gets 1 weekend off a month. But they've also indemnified the GPs at a cost of £10,000 per GP to be the second person present at a birth. They have around 20 births a year in the Scilly Isles. We have about 10 in Alderney, or 10 pregnancies. Of those 20 in the Scilly Isles, 10 will voluntarily choose to go to Cornwall and 10 will stay in the Scilly Isles. But they have said that they probably won't be able to recruit to that midwifery position in the Scilly Isles going forward. You know, it is a fairly niche position, isn't it? Is the current method, or was the current method of transfer appropriate? Not really, because it was very unclear, really. Also, the new aeroplanes meant that they had to have 2 pilots. There was a shortage of pilot hours, which meant that out of hours you couldn't get off Alderney at least 60% of the time. It just really wasn't clear. The lifeboat don't really like you asking them to do it because that's not their priority. search and rescue. Their priority is searching and rescuing, so if you ask them to do a maternity transfer but they're looking out for a vessel in distress, they won't transfer Our Lady because their priority is search and rescue. And did we provide any training at all for anybody in Alderney? So no, we didn't. So were we being effective? Did we audit care? No, and strangely, although I was able to come up with the amount of births that there have been in Alderney, I couldn't actually get the data without actually having to trawl through it all manually of how many babies were born in Guernsey with an Alderney address since the year 2000, so we weren't really collecting that data. Were we communicating effectively with the population? No, and we got the impression that women, having had those 23 births since the year 2000 in Alderney, were maybe a little complacent and thought that since those births had been relatively problem-free, that it was actually a safe thing to do, was to give birth in Alderney. And there was also a certain amount of kudos, perhaps, if you're an Alderney resident, associated with actually being born on the island. Were we making effective use of resources? Possibly not. Was our multidisciplinary team working effectively? We didn't really seem to have any communication with the GPs in Alderney. The midwives were going over every 2 weeks to do an antenatal clinic, but we didn't seem to have an inclusive approach. Did we have any user involvement? We didn't have any users or a user group like we have Maternity Voices here in Guernsey, but we don't have that in Alderney. So were we caring? We didn't feel that we were really providing a safe service. And once we were aware of the situation, we needed to take action to protect the pregnant women in Alderney and to prevent them from avoidable harm. We weren't really being responsive to the to the needs of the women in families in Alderney because we weren't really communicating the risk of giving birth in Alderney to them. And then we weren't really learning from the incidents of the births that had occurred in Alderney. And so therefore, if we weren't actually having robust governance systems, then we couldn't really learn lessons. So the senior managers at HSC hadn't been fully aware of the transport situation and weren't really fully aware, I don't think, of the unpredictable nature of childbirth. And there was no clear clinical lead for the maternity service in Alderney. So we needed to provide a model of care that's acceptable to the women and families and train the healthcare providers in emergency response. So not in obstetric emergencies, but just in first response. So, could we provide a midwife for Alderney? Well, as I've said in the Scilly Isles, it's probably quite a niche position. It'd be quite difficult to recruit, I think, to that position. Having had a lot of experience in maternity services myself, I think, having been to Alderney, I think you'd feel quite vulnerable providing that service as a lone midwife. It would have a massive on-call commitment. We could deploy midwives from Guernsey, but I don't think that would be a particularly attractive proposition, really, especially to some of our more junior band sixes. So that's difficult. It's very unrealistic to provide resources for every eventuality in Alderney, but we could provide accommodation in Guernsey where there's a safely staffed and equipped maternity unit which provides women with choices around birth. And we also thought that if there was a midwife in Guernsey, is that going to create a false sense of reassurance? Because actually, as a midwife with your Pinards, this is just it, really. There's a national caesarean section rate of around 27%. And it's thought that only 20 to 25% of women will give birth physiologically without needing midwifery or obstetric support. Financial. This is a difficult one in childbirth because we always come back to the negligence claims, and I think the biggest one to date has been about 17.3 million. And also in terms of informed consent, we have the Montgomery judgment, and that was where a lady was awarded 9.3 million. She said that had she been aware of the risks for her particular situation, that she would have chosen to have an elective caesarean section. And that was all around her understanding and how the risks had been conveyed to her. That's very interesting going forwards as to what repercussions that will have around informed consent. So given the potential losses, a business plan could be presented, but we're never going to do a business plan to provide a maternity unit with all that needs, the theatre, obstetricians, blood bank, etc. in Alderney. But we were okay with the financial side of things. And there are intangible resources as well, aren't there? So weather time, the comprehension of the population around the risks, their willingness to engage, and the reputation of HSC. So plan A was to do nothing. So we considered these 3 plans. That's not acceptable. The current situation was potentially unsafe and financially risky. Plan B was to provide a midwife in Alderney, which was probably going to be expensive and unlikely to be popular with midwives. So Plan C was to communicate the risk honestly and encourage women and families to travel to Guernsey prior to their due date to be negotiated on an individual basis. So we wrote to all the women asking them to do that. So the cost analysis, the potential cost of doing nothing is potentially 17.3 million is the biggest negligence claim so far, and loss of reputation. The cost of training would just be 2 days of midwifery time, so that's okay. Accommodation is cost neutral to us, and the administration costs of the plan that we decided to go with is minimal. We do have some potential disruptors, which is the weather, pregnancy and babies, all of which are notoriously unpredictable. And we now keep a record of all the due dates and plans for travel and accommodation. We keep records of all births with an Alderney address. We have effective communication with women in a multidisciplinary team, and that's just going to be supported because we recently won the Bursary Awards, so we're going to use some different technologies to keep in touch with them, and we've provided a day of first response training annually. So it could be said that we've taken the choice to birth in Alderney away from women, but actually we're giving them more birth choices by bringing them to Guernsey. They can have epidural, they can have water birth, they can have all the choices that all women in Guernsey have. So far so good. There's not been a baby born in Alderney since March 2017. And although the plan to come to Guernsey prior to your due date hasn't been entirely popular, I think it is safe, and we've got ongoing work around that. So we're going to do a focus group in January next year. We do have good communication with somebody who has had reason to be very unhappy with us in the past, but actually our relationship with her is really good at the moment. And she's now saying that she's communicating to everybody that it's safer to come to Guernsey prior to your due date. We have had some issues around accommodation, so we're going to meet with Joanne Leck and talk about that, so going forward. And I know that this issue isn't just for maternity services, really. Patients from Alderney can't get on morning lists in case they can't get here. So there are lots of stuff around accommodation. And also, I know that the population of Alderney do want their own midwife and their own monitor and their own obstetrician. That's for maternity patients, but I'm also sure that if you spoke to a cardiac patient, they would want all cardiac services in Alderney as well, and if you spoke to an oncology patient, they would want that as well. So it's quite a difficult situation we find ourselves in. We have done some inductions of labour for ladies from Alderney. Induction of labour is now seen to be safe. The Royal College of Obstetricians and Gynaecologists have clearly said that induction is safe. And although it might not be thought to be ideal, the situation in Alderney is not ideal either. But we do negotiate everything on a completely individual basis. And each and every one of us has a part to play in continuously improving maternity services in Alderney going forwards, and it's very much a work in progress. So if anybody has any good ideas, please feel free. That's it. Thank you. Any questions?
So as Vicky said, I'm Dawn Watson and I'm the risk management midwife up in maternity. So risk management for healthcare entities can be defined as an organised effort to identify, assess and reduce where appropriate risk to patients, visitors, staff and our organisational assets. And I like sort of risk management in its best form may be used in a proactive manner in identifying and managing risks. Now, I don't know about everybody else, but sort of being the person who predominantly gets all the incident forms, we do a lot of our risk management as a reactive, sort of to things that have actually happened, and and trying to fix that after the fact. So I'm sure you all know that risk management is a continuous cycle. This is kind of based around a risk register, but it's a similar thing. You identify your risk, you're analysing and evaluating that, you're communicating to all the various people involved, monitoring, reviewing that, and then you go back and start again to see what, like, sort of, have we done that right? Have we achieved what we were aiming to achieve, and have we reduced the risk? So when I took up post a few years ago, we didn't really have any way of monitoring what our incidents were, what our trends were, you know, sort of what were actually our outcomes in maternity. So we've developed that over the last few years, and we're now using a lot of infographics and monitoring our trends. So we report monthly to our governance meeting of all of our incidents, both monthly and over a quarterly trend, and we can obviously discuss ideas of how to improve those trends at those meetings. We have our maternity dashboard, which is, you won't be able to see that, apologies for the terrible graphic in the middle. So that looks at all of our outcomes, so caesarean section, number of births, smoking status, number of women who've had vaginal birth after caesarean section, various different things, and we look at our monthly outcomes. And every quarter we also compare how we are doing in terms of other island maternity units as well. So we compare ourselves to Jersey, and we compare ourselves to the Isle of Man and Portsmouth, who we've got a partnership with. And then I also monitor an incident spreadsheet. So every incident that we have within maternity goes on that spreadsheet, so we can monitor what our findings were, what our action plan was, and then they audit, you know, sort of the ongoing audit of those actions. So I pulled these definitions just out of the dictionary. So what is a trend? So a trend is a change or development towards something new or different. A general development or change in a situation or in the way that people are behaving. And to set a trend means to do something that becomes accepted or fashionable and that a lot of other people copy. So I thought, like, sort of, if you think about that, you know, sort of change is never popular within maternity services or hospital service in general, or in life basically, is it? And, you know, sort of, we think a lot of the things that we've done, you know, sort of, because it's come from an incident, we've looked at what can we do to make it better, and we've implemented the change. It obviously hasn't always been popular or successful, you'll find out. So these were some of the trends that we identified. So around documentation, I'm sure most people can identify that one. Delay in transfer to theatre. As many of you will know, we're not on the same floor as theatres, so we have to go down in the lift system. An increase in needle stick injuries, improving the accuracy of blood loss, underestimating blood loss, massive hemorrhage, PPH, bladder retention, and an increase in hospital readmissions. So those were just a few of the things that we've pulled out. So as you can see, that there were quite a few around blood loss on there, so I thought this was quite an interesting piece of work that we did. So initially we identified that we had a lot of patients who were becoming anemic. When we look back, we think, we've obviously got an underestimation in blood loss. So we thought, right, okay, to counteract that, we'll implement weighing of swabs so we get a more accurate blood loss. That led to an increase in our rate of PPH, which wasn't unexpected, because we think, right, well, great, we've achieved what we were wanting to do, we've got more accurate measurements, and now we can obviously treat those accordingly. As part of that, what we decided to do was to implement something called Code Blue within the 222 system. So that was a simple way of, you know, sort of, if a woman was having a massive obstetric hemorrhage, we'd dial 222, Code Blue, and we'd get everybody that we needed to come. As part of that, we put in an estimate of blood loss of 1,500 mils, thinking that, you know, that is a substantial blood loss and we definitely need to be doing something about it. And having implemented that, we actually saw an increase in our massive obstetric hemorrhage rate, which was the opposite of what we were expecting to see. And it turned out that that wording of call Code Blue when you reach 1,500 mils with ongoing bleeding was actually delaying staff calling the code blue, because they were actually waiting to get to 1500 mils before they called the 222. So we were thinking that we'd done a great initiative, and actually we created something that was worse than what we had before. So we went back, we reviewed it, we looked at the system, found out where we were going wrong, and we took out the blood loss, sort of a specific volume of blood loss, and just said with significant ongoing bleeding, and we changed it from code blue to massive obstetric hemorrhage. Because that, sort of people were also getting confused with terminology. And actually, since that point, we have seen a decrease in the number of massive obstetric hemorrhage. We'll never get rid of postpartum hemorrhage, it's part of having a baby. But yeah, significant obstetric hemorrhage has decreased. So this was the thing that we didn't account for. Every group develops its own customs, habits and expectations for how things will be done. These patterns and expectations, or group norms, influence the way team members communicate with each other. Norms can help or hinder a group in achieving its goals. So we hadn't actually anticipated how the individual members of staff would interpret that guideline, and how everybody else would then follow that norm, and and how those couple of people interpreted it. So just another few definitions. So change, general development of change in a situation or in the way that people are behaving. So again, we didn't anticipate that. To set a trend means to do something that becomes accepted or fashionable and that a lot of other people copy. But we need them to copy the right thing. So our key learning points. Trends can be both positive and negative. Even when you're going for the positive, you can actually create a negative. Focus on the system in place and how this can be improved. Train and educate all staff around the changes. So you've got to get the same key message to every member of staff. Don't give that message to one group and expect them, because it turns into a bit of Chinese whispers and it gets diluted along the way. Train together with all members of the multidisciplinary team. So don't just do it, to your ground level staff. You need to do it to your senior staff, the medical staff. Everybody needs to train together. Identify human factors. People influence people, and they don't always behave as you expect them to. Review and audit the changes in a timely manner to ensure that they are having the desired effect. Repeat the cycle, review it, improve it, and audit.